Chapter 9 this week is going to be on Peri-Implant Health and Diseases. This starts in your book on page 161 and 160. Section 1 is going to be the anatomy of the dental implant and surrounding peri-implant tissues. So first of all, what is a dental implant? A dental implant is a non-biologic, which means non-living, device surgically inserted into the jaw to do these two functions. So first it's going to replace a missing tooth, and it's going to provide support for a prosthetic denture. It can do either, not both. A dental hygienist is going to play an important role in the patient education and the professional maintenance for the dental implants. So over 3 million Americans living right now have dental implants, and this number is projected to grow by over 500,000 per year. They've certainly grown in popularity, and patients find them a wonderful alternative to having a bridge or a partial or a denture. Dental hygienists have to be able to distinguish between peri-implant or around the implant health versus peri-implant disease. Managing and the maintenance of implants is very different than it is for natural teeth. So we need to be educating our patients, and we need to be behaving as far as our treatment of implants differently than how we do for natural teeth. For those of us who don't have implants, it's a good idea to understand the different components or the anatomy of a dental implant. And so first is the implant body. This makes up the root portion of the implant, and that one is going to be surgically implanted or placed into the living alveolar bone. And then on top of the abutment, it goes the abutment. On top of the implant body is where we put the abutment. And this is a titanium post that attaches to the implant body. And it's going to protrude, which means stick out, partially or fully through the gingival tissue. This is the part of the implant that's going to connect to the crown or the denture, depending on what they're putting on top of the implant. It's important to note here that both of these things are made out of titanium. Usually, that's kind of the standard, but not always. There are other materials that can be used. What's most important about the titanium and any type of material that they use for the implant body or for the abutment is that it has to be biocompatible. That means that our bodies won't reject it. If we were using other types of material, our bodies would not, accept that material into that area. So then this is what that looks like. This right here, not including this part, this screw-shaped item, that is the actual implant body. And then this part right here that connects to the implant body is the abutment. So here, right here, we're seeing just the implant that is getting placed into that area. And then this thing right here, this is the abutment. And then on top of that, this one over here, this is the crown that goes on top of the abutment. So the implant system consists of the implant body, right, that gets surgically placed into the bone, the abutment post, right, that connects the implant body with the crown, and then an implant crown, which we place on here. This image right here is showing us a screw-retained implant crown where they put the crown on top and then they put the little screw above it. Usually they fill in this like little section right here where once the screw is in. Not all implants are screw-retained like this. Some of them are cement-retained, but we'll get into that. This is what an implant and its components might look like. If you see it, it's usually packaged in like a sterile little package, but this is kind of what it looks like. It's a little implant part. This part right here is, sometimes it's considered a healing cap. They'll put it in there and then they let the tissue kind of grow in around it. And then this part right here, you can see this is the abutment that is already attached to this implant right here. These are the different types of implant, like materials, so they're using usually titanium abutment. Most of them are made of titanium. However, what we're not liking about titanium is that in certain areas where the bone and the tissue is thin, this gray color really shows through. And so what they're trying to do is find other biocompatible materials that they can use that are tooth colored so that it will look like natural teeth, right? So here they're doing kind of a combo where they place the titanium implant and then they're putting a zirconia abutment. Zirconia is used a lot in crowns. It's one of the hardest materials that we can possibly find in dental restoration materials, which you guys are learning about in dental materials probably. And what's really nice about it is that it doesn't fracture as easily as other materials do. It's very scratch resistant and it is biocompatible. And then right here, the zirconia implant with the zirconia abutment above it. I really feel like this is probably the future of implants themselves. This one right here is used probably more likely on anterior teeth right now while they're still kind of in its early stages, whereas this, titanium on titanium is probably used more often in posterior sections or in areas where, they don't have access to this newer materials. So here, what they do is they'll put the implant in, and then they'll put this thing here, which is actually called a healing abutment, or sometimes you'll hear it referred to as a healing cap. They put it on top of there so that the tissue will grow and heal in this area around the implant. They don't want it to grow completely over because then they'd have to surgically cut it open again in order to put the abutment in. So they put on this healing cap so that the tissue can heal around it. But what it does is it makes sure that these implants aren't being used when that person is chewing, because we want the bone to heal and we don't want to cause it to have any kind of trauma from the occlusal forces. This is what that looks like as far as a partial compared to implants would happen. So the partial really relies on this tooth and this tooth to support it, right? It gets food caught underneath and the patient has to take it out and clean it. And then over time, these two teeth, the ones that the partial are clasping onto, those teeth, if they, have any type of wear or, if they have any type of issues, then those teeth are a lot more susceptible to being lost as well. Whereas with this implant, this tooth and this tooth are perfectly fine. They function just like how they used to. They don't have any extra strain on them. And now there's three implants right here that are going to support that area. This is what that surgical placement would look like. So, first they have nothing, and they drill a small little hole. Well, they're lifting the tissue, and they drill the small little hole, and then I guess they make it a little bigger, and then they put in the implant, and then they actually they'll put the tissue around that little healing abutment, or they'll sometimes even cover it back up with tissue. Peri-implant tissues, this is the soft tissue surrounding the dental implant. It's very similar in a lot of ways to the periodontium of a natural tooth, but there are pretty important differences. So first of all, we have the implant to epithelial tissue interface. And so we know that in a natural tooth, we have sulcular epithelium and we have junctional epithelium. But with an implant, there isn't really any cementum for things to attach to. So the epithelium is going to adapt to the titanium abutment post, and it's going to create a biologic seal. However, that seal is not going to be as good as junctional epithelium. The biologic seal is going to function as a barrier between the implant and the oral cavity, but it's a weaker type of seal. And then the sulcular epithelium that surrounds the implant abutment post, that sulcular epithelium is still going to be there. You're still going to have a sulcus, and you're going to be able to probe those areas, but it's just different. The implant to connective tissue interface, so this is where things become significantly different because implants don't have cementum, obviously, right? There's no PDL or periodontal ligament around an implant. And so gingival fibers and periodontal ligaments cannot insert into the titanium surface, right? There is no Sharpie's fibers embedding into the titanium surface. Periodontal pathogens can destroy bone way faster along a dental implant than in a natural tooth where that periodontal ligament is protecting. As far as the implant to bone interface, there is something called osseous or osseointegration. It is the direct contact of bone with the implant surface. This is the number one. This is why implants work. This is how things happen. So they put that sort of screw into the bone, and then the bone grows in and kind of adheres to the implant. Titanium itself is somewhat soft and it's a bit more porous, and so it has that ability or the capability for the bone to really attach and adhere to the implant. The osseointegration is successful if, one, there is no mobility around that tooth. Any type of mobility on an implant is a sign of failure. Absence of inflammation of the tissue. So we don't want the tissue to get really inflamed and red because obviously that would be a sign of infection or of rejection. No discomfort or pain when functioning. So, if the person is biting and they're biting harder on that tooth than the surrounding teeth, then they're going to probably feel some pain in that bone. And then we don't want to see any increased bone loss or radiolucencies around that tooth. And while a certain amount of bone loss over a very long time is considered normal, we don't want to see any increased bone loss. So we're going to talk about that. This is the difference here. We have the sulcus here on a natural tooth. Let me choose a different color besides red. Sulcus here and junctional epithelium. Everything is attaching nicely to the tooth. And then there is the sulcus depth here is the biological width. Then we have supragingival fiber bundles that attach right into the cementum. Mucogingival junction, obviously that's where the attached gingiva happens, the bone here, and then the periodontal ligament, right? See all of this wonderful periodontal ligament, almost like a little shock absorbing area. Then we come over here to the right side, there is still a sulcus and there is a abutment connection. The tissue does, to a certain degree, not like quite attach per se, but it does, seal up next to it. And then these supragingival fibers, though, they don't connect. And so this tissue attachment is very, very weak. And then here we can see that the bone just straight up attaches in this pattern. The reason we use this screw pattern is because it has more surface area for the bone to kind of absorb to. We don't put anything smooth down in there because we want the bone to osseointegrate. Tissue surrounding the dental implant. So here we have the junctional epithelium, which does attach to the implant surface with a biologic seal. It's very weak, but it does essentially attach. Then we have connective tissue, which runs parallel and encircles the implant, but the connective tissue doesn't attach. Connective tissue doesn't attach to a real tooth, so that makes sense. And then periodontal ligament in an implant, there is no PDL. A cementum in an implant, there is no cementum. And then alveolar bone, this is going to make direct contact with the implant surface. So when we discuss, when a tooth becomes ankylosed, it's lost its PDL space and the bone just attaches right to the tooth. The same thing happens with every single implant. If you think of every single implant you ever come in contact with as being ankylosed, then you have a good idea of how it will function. Moving on to section 2, Peri-Implant Health, Diseases and Conditions. So first we have Peri-Implant Health. We need to talk about what that looks like. It's going to be characterized by an absence of erythema, right, which is redness, bleeding upon probing, which is light probing. Obviously, if you have heavy probing, you'll get some bleeding, swelling or edema, and suppuration. Any type of suppuration is usually a sign of something has gone horribly wrong. It does not appear clinically different from clinically healthy periodontal tissues. So the tissue around an implant, aside from, if there might be any like grayness showing through because of the implant, the tissue itself should be the same color, the same texture and consistency that the other teeth have. Probing depths can be deeper. They can be more shallow compared to a healthy tooth site. They're going to be different. And the difference here is due to the orientation of the connective tissue fibers. So it's not necessarily like you're going to get your 1 to 3 millimeters is going to be healthy. The implants don't work that way. You'll find that after the implant has healed, you probe it, and whatever those numbers are at the initial implant placement, or after the certain healing period, that's kind of your baseline. And from there, if you see progressive pocketing, then yes, that's cause for concern. But if your initial is a 5 millimeter pocket, then that's not necessarily unhealthy. That just could be the shape and the size of the implant itself. So here's what that might look like. You can see that there's some areas where it's a little darker, but for the most part, like there's kind of like a grayish hue here. Where the same, I mean, there's this is a porcelain fused to metal, so there's still this grayish hue on the tooth right in front of it. And so whenever you're seeing that gray hue, that's not that's not that cyanotic tissue. That's the color showing through. But as far as the tissue goes, you're seeing this very light, healthy pink color. And that's important. And then here for the radiograph, you're seeing that the bone in all of those areas where the implant has that texture along that screw, the bone is osseointegrated. If you're starting to see some of those screw sort of marks as that bone recedes, that's usually a sign that some bone has been lost. Here around these teeth, you can see very uniform color, except for what's going on here, right? Something is definitely happening around this tooth. And then here around the bone, we can see that the bone level, for the most part, is staying fairly stable. I wish I could kind of zoom in because this one's a little suspicious. But then here, these look fairly normal, except for this little line right here. And then I feel like I'm seeing a little bit of a radiolucency, like a little fuzziness right there, although I don't have anything else to compare it to, so I can't be totally sure. Peri-implant disease, so peri-implant tissue inflammation. Here we're going to see plaque deposits on the implant that can cause inflammation of the soft tissue or the gingiva around the implant. And as the disease progresses, partial or total loss of osseointegration can occur. There's two forms of peri-implant disease, just like periodontal disease. It has two types. Peri-implant disease has first peri-implant mucositis, or if you just think of this as like the mucous membrane itis, is also known as peri-implant gingivitis, is going to be plaque-induced gingivitis in the tissue surrounding the implant. Peri-implantitis, which is going to be periodontitis in tissues surrounding osseointegrated implant, which will result in bone loss. Peri-implant mucositis, also called gingivitis, plaque-induced inflammation of the soft tissue. However, just like with gingivitis, we aren't seeing a loss of supporting bone. When we start to see the bone loss, that is the change from mucositis to periodontitis, or implantitis in this case. Peri-implant mucositis is reversible if the plaque is removed and removed consistently. If not, it can certainly progress to peri-implantitis. This occurs in 80% of patients and in 50% of implant sites. So what we're seeing is that a lot of patients have, mucositis, but not all implants can get it. There's factors that go into why they might get implant or mucositis around a tooth, and some of that isn't just that the patient isn't brushing and flossing properly. Some of that is the shape and the contour of the implant itself. So mucositis requires close monitoring to notice signs of mucositis. And these are going to be redness, swelling, bleeding upon gentle probing, and increased probing depths. So not necessarily that we have a deep pocket, but that the pocket is getting deeper. Does that make sense? Like, before it was a 4, and if today it's a 4, yeah, a 4 is like considered unhealthy, but because it was a 4 before and is still today, it's not a bad thing. That's not an increase. We only compare what we had before to what we're seeing now. This is what peri-implant inflammation might look like, or mucositis. We can't tell without probing depths whether this is mucositis or implantitis, but we can definitely tell that the tissue there is not healthy. Peri-implantitis is going to be periodontitis that affects soft and hard tissues surrounding a functioning osseointegrated dental implant. This is typically caused from plaque biofilm-induced inflammation, and there is a progressive loss of the alveolar bone. So, you spent all that time healing and worrying about osseointegration, and then the bacteria invades that area, and it will cause the bone to, recede away from the implant. It can progress in a nonlinear and accelerating pattern. So just like with periodontitis, how you have certain areas where things get worse, and then you have areas where those sites become inactive, you can have the same sort of situation with peri-implantitis. So it can, have certain areas, or certain times where it gets worse, and certain times where it doesn't. The prevalence ranges from 6.61% to 47% of cases. I don't know about you, but that's a pretty wide range there of cases, and I have a feeling that there are more factors involved here than just plaque biofilm. So, don't just automatically assume that the patient isn't taking care of it. As far as the diagnosis, you're going to need to have signs of inflammation, right? So bleeding upon probing, upon gentle probing, bleeding, separation, any type of redness, edema, and erythema. And then increased probing depths. So we're seeing, from before to now, an increase, and then a progressive bone loss seen on radiographs. So in order to, diagnose implantitis, it is the same sort of criteria as diagnosing periodontal disease. It's not just, the redness, inflammation, and bleeding that tells us that this is active. It's also signs of damage. So peri-implantitis is going to begin at the coronal portion of the implant, while the apical portion continues to be osseo-integrated. What does that mean? It means that you're going to lose bone from the crown, and it's going to slowly go down towards the apex, or like the tip of the implant. The implant does not become mobile until the final stages of disease, which is kind of sad, because the bone at the bottom is ankylosed. It's tightly holding on. It doesn't become mobile until that bone down at the bottom is completely, it has lost some of its osseointegration, and so that can be pretty difficult for patients. And then mobile implants that show signs of loss of osseointegration should be removed. That's a pretty big loss, because patients pay a lot of money for their implants, and they really want them to last. Radiographic signs of implant failure. So this is going to be vertical destruction of crestal bone around the implant. And we'll typically see this kind of in a progression over time, but if you're seeing someone for the first time and they have a lot of vertical destruction of that crestal bone, then it's okay to call it kind of without that longitudinal data. And then the bottom portion of the implant remains osseo-integrated. So, it doesn't have to be completely mobile. It doesn't have to be, completely ready to fall out already on its own before you can call implant failure. And then it can have wedge-shaped defects along the implant, and we'll see images. So here, this is that implant radiolucency, and this is what they're talking about, that wedge-shaped sort of. That's a terrible drawing. It's hard to draw with a mouse. So here we're seeing that wedge shape. That's interesting. And then here we can see this kind of radiolucency along this area here for that vertical radiolucency. this implant isn't doing too good. Here we can see kind of definitely some bone loss around this implant, and then in this image it looks like it's definitely gotten worse. You know, sometimes with bone loss on natural teeth it can be really hard to measure you know, how much bone loss has occurred over time, but with implants it's actually easier because they have those little threads of the screw. You can just count the threads and see, you know, exactly how many threads the bone was attached before to now. Another key point here is back to radiology, is that when we're taking these images, it's important that we use long cone paralleling technique. That way we're not foreshortening or elongating any of these images, because we are relying so heavily on our periapical images to be able to determine how much bone is around these teeth. We have to be able to see it consistently from the same angle. So use paralleling. Again, peri-implantitis, we can see, even if it seems really fuzzy like this, we can see that there's definitely something going on around this one. And then if you'll notice, there's this little bump right here on the side, and then this little bump right here on the side. Now this, it could be calculus. Odds are it's not calculus. Odds are that this is cement that was left over from when the dentist cemented that crown onto the implant, and that cement is actually causing a site for bacteria to adhere and to kind of burrow under, and could be, not for sure, but it could be the cause of the infection here. Also, my green drawing kind of looks like two little eyeballs, and then like here's the nose. But anyway, again, we're seeing that bone loss around the implant right here in the middle. Ideally, we'd probably want the bone to sit right here and right about here, but it is not. Recognition of peri-implant diseases. So peri-implant disease etiology, what causes these peri-implant diseases, right? Etiology always means what's the cause. So both forms share common etiology. There could be polymicrobial bacterial infection, polymicrobial meaning more than one type of bacteria, or it could be biomechanical forces, and we've touched a little bit of both of these. So first is bacterial infection, periodontal disease in both the periodontium in natural teeth and the peri-implant tissues of implants progress in a similar fashion. It's, you know, the bacteria causes inflammation, our bodies respond to the bacteria, and over time the bone and the tissue around the teeth recede. Both bacterial plaque, biofilm, and host response are required in order for either of these to be considered. Perimucositis does not always progress to peri-implantitis, just like gingivitis does not always progress to periodontitis. And the rate of destruction is more rapid in peri-implant tissues than in natural dentition, right? So again, more rapid. If they're taking the time to tell you which one is more, you're probably going to want to remember it. What's important here to note is that we learned about the structures around the implant. So because the structures around the implant are inherently different from the structures around a natural tooth, that is why there is a more rapid destruction in an implant tissue than in natural dentition. Our natural dentition have a defense mechanism put up in place to prevent that rapid deterioration of tissue, whereas implants don't have that natural defense. Risk factors for peri-implant failure. So obviously a history of previous periodontal disease. You know, if they have that bacteria or they have some type of condition or, you know, inflammatory response to certain bacteria, then they're probably going to be at a higher risk for implant failure. Poor plaque biofilm control. If it's someone who, you know, just doesn't value or isn't capable of being able to remove plaque biofilm effectively, then they're not going to be able to do so on an implant either. Smoking, this one again, it just reduces our body's ability to fight infections. It reduces it changes our body's response to bacteria and our immune response, and so smoking is going to be a big big reason why implants might fail. I've met several dentists and oral surgeons and periodontists who will not place implants on patients who smoke. They just won't do it. It's just a waste of the person's time and money and effort. Residual cement. So this is the one we talked a little bit about. I showed you the images for it, but residual cement is going to potentially cause an implant to fail. And then biomechanical overload. So this one we'll talk about more too, but biomechanical overload means that when the person bites down, that they hit that implant harder than what the implant can withstand. And we understand that the implant is ankylosed or osseointegrated into the bone. So there's no shock absorption from the PDL happening. And so if that bite or the occlusal forces are hitting the implant so hard that it isn't able to heal, it's going to cause trauma around that area. So here is an image of what that residual cement might look like. I'm guessing that's this, although I feel like that might just be the shape of the implant, not totally sure. But I mean, here this is just an example of how residual cement will certainly cause some bone loss in this area. Biomechanical overload, I just kind of explained it, but collective forces that are placed on the implant. And this gets influenced by a couple of factors. So one, the position of the implant fixture. So depending on where it is and how high it is among the other teeth, that's going to play a role. How important is that implant in someone's chewing capability? Do they have natural teeth around the implant to kind of help, or is the implant doing all of the work, right? The number of implants supporting a prosthesis. So if you have an area that is taking up the space of 4 teeth and you have one implant doing all of that work, it's probably going to fail. It's going to have more of a workload basically than if you had 4 implants taking up the space of 4 teeth. Then it's a lot less likely for those implants, because many hands make light work, right? Or many implants make light occlusal forces. The occlusal force distributed among the implants and the remaining teeth. So just depending on, how spread out the force is, may the force be with them. Biomechanical overload. So the implants lack the protective structure of a periodontal ligament. We talked about this. If we consider the PDL as kind of those shock absorbers, the implants don't have it. Implants are in direct contact with the bone. They are ankylosed right to the bone. The forces placed on an implant are transmitted directly to the bone. So, anytime you crunch down on ice or an almond, it's going to take all of that force directly down into that osseo-integrated little threads, and, whether or not they can hold up over time. It is critical to minimize the forces that are placed on an implant. A lot of the time when dentists are placing the crown on top of the implant, they will put the implant at a slightly lower place than the natural teeth, than the occlusal plane, basically, where the teeth naturally touch. And they do this to try to minimize those forces. Most of the time it takes time. They place the implant body into the bone and the healing cap usually, and they will let it heal for a certain amount of time so that the bone can osseo-integrate, right? Usually takes anywhere from 3 to 6 months is what I've seen most common. That's not necessarily how long everyone lets them heal, but that's kind of the average or the standard. And so those 3 to 6 months are crucial. If, however, someone is getting an implant in an area where they're like, no, I need a tooth right now, right? How quickly you load forces onto that tooth after placing the implant is going to play a role, because how long did that bone get a chance to osseo-integrate before it started to have to work, basically. If it has to start working too soon before it gets a chance to osseo-integrate, it's more likely to fail. The detection of a failing implant. This is sad. So clinical signs in a soft tissue, we're going to see a peri-implant pocket, right? So we're going to see a deep pocket, deeper than what it was at its baseline. We're going to see bleeding around that area, suppuration or pus, right? You're going to be able to press against that tissue around it and have that kind of exudate come out, and then possible swelling in the tissue around it. However, just like with regular periodontal disease, we don't typically see pain in these areas. Our bodies kind of fight this infection, they fight the good fight without having us have to be present for it. So pain is not a typical symptom of peri-implantitis. Usually when people get implants, they're very aware of the implants. They're very aware of the ability that the implant can fail. And so people who have implants are usually very receptive and they're very concerned when you kind of show them some of these signs and symptoms. But that doesn't mean necessarily that everyone who got an implant is coming back in for their routine maintenance, on schedule kind of thing. So if you catch it and you explain it to them, usually they're pretty receptive and they understand a bit better. Changes to the bone support. So mobility is the single best indicator of implant failure. If the implant becomes mobile, then there's not a whole lot that anyone can do. It should not be mobile if the implant is healthy. It can indicate the presence of a loose abutment or the rupture of a cement seal. So because we know there's 3 parts, right? What happens if the implant itself in the bone is nice and healthy, osseo-integrated, just like it should be? But then comes along the abutment, and the abutment, as it got screwed in, didn't stay screwed in all the way, right? It becomes loose. And so when we're measuring, we're feeling that movement or the mobility, but it's not the abutment in the bone, it's not the implant in the bone, it's the abutment in the implant that's mobile. Or it could be the crown on top of the abutment that's mobile. And so, before you freak out your patient and say, we're going to pull this implant out, right? You wouldn't say that anyway because you're a hygienist. But, before anyone scares that patient into thinking that their implant has failed, we do have to do a little bit of digging to make sure that it is the implant in the bone that has failed. Severe mobility can be associated with pain because it could be that there's a fracture in the implant or in the bone around the implant, and then that would indicate pain. So the radiographic signs of failure, here we have that vertical destruction of bone around the implant. The bottom portion of the implant could still be osseo-integrated. It could still look very radiopaque around that apex of the implant, and the radiolucency indicating bone loss adjacent to the implant. So when we see that radiolucency, we know that there's that vertical destruction or destruction of any kind of the bone around the implant, and we know that something needs to happen. I'm sorry they do construction at my in my area. Anyway, treatment modalities for failing implants. So non-surgical periodontal instrumentation is the first step always, just like with normal teeth. When we see some of those signs and symptoms of disease, we want to intervene in the least invasive way. So non-surgical periodontal instrumentation or scaling, right? Then the use of antiseptics. So we might give them some type of rinse or some type of it's a rinse, it's an oral rinse, and then local systemic antibiotics. So we'll talk about this a lot in Term 7, but there is, Arrestin or PerioChip or even chlorhexidine chips that can be placed down into those pockets. That is a antibiotic that is directly given in that site. Or if the patient has kind of a lot of issues or they have a systemic condition happening as well, they might even be recommended to take systemic antibiotics. This is kind of an older version. We used to think that giving someone a systemic antibiotic could help with their periodontitis, although the research is inconclusive when it comes to that. So that one isn't practiced as often. And then flap surgery. This is where a periodontist will, basically remove all of the tissue around the implant, and because the bone is already receded as well, removing just tissue will expose the implant, and they will clean essentially that area really well. Most of the time they'll put in a bit of a bone graft kind of situation, and then they'll close that tissue back up. It remains available evidence suggests subgingival air polishing with glycine powder may reduce mucosal inflammation. So this is new information for me. I didn't learn this when I went through hygiene school, also because we didn't have the new staging and grading when I went through hygiene school. But so air polishing with glycine powder, that is pretty new. Moving on to section 4, clinical monitoring of peri-implant health and disease. So while, it's not our job to place an implant, of course, it's not our job to cement an implant or to, place the screw that holds the implant. It is our job to recognize those signs of diseases, and it is our job as hygienists to basically do most of the clinical monitoring of that peri-implant health and disease. So clinical monitoring is going to be that routine monitoring of implants. It's a part of a comprehensive examination and the maintenance, and is essential to effective management of peri-implant disease. So when it comes to implants, you are kind of the person who watches and makes sure you're kind of like the security guard, making sure that the bacteria doesn't get into those areas, it doesn't start to cause, inflammation. If you can catch it while it's still mucositis before it becomes implantitis, then you will have saved that patient a lot of money. You'll have saved them a lot of time and effort, and you'll be overall helping their oral health. And I think that we get kind of looked over when it comes to this, but your patients will be grateful to you if you can identify some of these issues, if you can identify some of these signs before they become irreversible. So important data collecting procedures. Of course, we rely very heavily on our probing depths, right? Gentle probing. We want to assess those clinical attachment levels for clinical attachment loss, right? I think that I'm going to always have to say both. Every time I see any cal, I'm going to be like, oh, the clinical attachment level and the clinical attachment loss, because they're just both in my head. We want to assess them for bleeding upon gentle probing. Now your book does say that if you are a bit heavy-handed in your probing and you get bleeding, that is not a sign of mucositis. It's not a sign of implantitis. It is a sign that you have a heavy hand. So be very mindful of this. We're going to assess for evidence of separation. So when we're going around and probing, usually, you'll stick that probe in there and it'll kind of, exudate will kind of ooze out, and so you're watching for that as you're probing these areas. And then you're going to collect routine radiographic evidence of health and disease, and you're all going to be wonderful dental radiographers using paralleling technique. Probing, when it comes to the initial probing depths that are collected upon seeding of the final restoration. Now, some surgeons will say not to probe an area until it's completely healed, because they don't want your probing to go in there and introduce bacteria around that tooth before the epithelium gets a chance to, attach in the manner that it's going to, okay? So it's really, really important that you don't probe too soon and you don't probe too heavy, because your probing will introduce bacteria. Your probing can, before it can puncture the junctional epithelium, typically the junctional epithelium can heal easily, but the tissue around the implant doesn't. So you either want to use really light force with either a plastic or a metal probe. Now this is new. Your book talks about metal probes and that they are safe for use around implants. This is a new concept. You'll find a lot of hygienists who, they've been keeping up to date with current continuing education, and they'll still say, no, you need to use plastic. You need to use plastic probes. You need to use plastic scalers. And that's simply not the case. We're going to talk about that. But you can use a metal probe around an implant as long as you're using light force. Clinical attachment levels. So you're going to want to collect baseline data to use as a reference point or initial probing, right? We talked about this already. So you're going to collect that baseline data, and then probing depths can be deeper than the 1 to 3 millimeters that we typically see in natural teeth. Healthy peri-implant sulcuses typically range from anywhere from 1.3 to 3.8 millimeters. So getting a 4 around an implant is actually totally normal. It doesn't indicate a sign of disease. What you're doing is collecting data. That's it. The depth is going to be dependent upon the thickness of the tissue around the abutment. So we talked about the different types of tissue, right? And how different people have, thin tissue or thick tissue. And so depending on the person, they're going to have different probe depths. And then another factor here is the shape or the contour of the implant. If the implant is sharply contoured, you're probably going to get more shallow readings, whereas if the implant is kind of more, less contoured, less curvy, then you'll get deeper readings. It's just sort of the way they shaped it. Bleeding on probing is going to be a good indicator of current tissue inflammation. So therefore, a lack of bleeding upon gentle probing will predict health. That's important. If bleeding is present, biofilm removal will reduce inflammation, obviously. Evidence of suppuration. This can be detected during probing. So you stick that probe in there and then you kind of watch the pus sort of ooze out. Record by specific area, so the tooth and the surface. This is really important that you are recording any areas that have suppuration, even on natural teeth, but especially in implants. This can also be detected by applying gentle pressure over the implant to see if pus is expressed. This is done with your finger. So if you probe a little bit and you see a little bit of exudate, but you're not totally sure, it's okay to kind of press your finger against that tissue on the side. It's not going to hurt the patient, and press to see if any more comes out. Radiographs, yay. So vertical bone loss of less than 0.2 millimeters annually following that first year of function, okay? So let's do the math here for this. So they have had the implant for 1 year, and wherever that 1 year mark is, that's going to be considered their baseline. And then let's say 5 years later, which is how long it would take, right? 2 times 5 is going to be 1 millimeter. They've lost 1 millimeter around that implant. That's normal, okay? So 6 years after implant placement, if they have 1 millimeter of bone loss around that implant, that's normal, all right? Any more than that, if they have 2 millimeters of loss around that implant, and it's been 6 years since they had the implant placed, that would be considered, peri-implantitis. Baseline radiographs should include the day of implant placement, the day of final restoration placement, and the day of maintenance visit. So here it's really important that we are comparing radiographs. We're not just looking at new ones. We want to examine the radiographs on the day of the final restoration placement for the presence of remaining cement. So anytime you have a dentist who is doing the crown over an implant, usually they'll do it like abutment and crown placement. They do both at the same time. You'll see that they will take a radiograph. This doesn't happen whenever they use a screw-retained implant because, the screw holds it on there and then they just put the filling material at the top of the screw. And then radiograph implant at least once a year. So while most of the time with patients, depending on their caries risk, we will refer to the dentist, and we might not take x-rays every year. We might need to only take x-rays every 18 months, sometimes all the way up to every, 2 years, basically. But for patients who have implants, we want to take them at least once a year. Moving on to section 5, the clinical guidelines for maintenance of patients with dental implants. So the maintenance of dental implants is going to be important for the success of that implant in the long term. It's going to be similar to maintenance visits for patients treated for periodontitis. So whether or not they lost that tooth because they had periodontitis or whether they got a cavity or they had trauma, for whatever reason that they lost those teeth and had to have an implant, they now kind of become periodontitis patients. We need to watch them a little more careful. Meticulous patient self-care is necessary to prevent peri-implant disease. Most of the time you'll hear where people think that once they get an implant, they can just treat it like a natural tooth. Oh, they just, floss it like normal and brush it like normal and they're good. They don't have to take any extra care of it. And they would be wrong. Goals for implant maintenance. So the maintenance of their alveolar bone support, the control of inflammation, the maintenance of a healthy functional implant, and the maintenance of healthy and functional periodontium surrounding neighboring teeth. The idea here is that if someone has bacteria that causes periodontal disease in another area of the mouth, that bacteria can be transferred to the implant and can cause your implant to fail. So it's important that they take good care of all of their teeth. Patient-provided information. So not inflammation. We don't want to give them inflammation. Daily self-care routine. So we want to be discussing with them not only what they should be doing in order to take care of those teeth, but have a discussion about what they're willing to do. Maybe they're not willing to floss with string floss every day. Maybe you have to convince them to floss with string floss once a week and get them to do a water pick every day. You really have to have a conversation with your patient in order to figure out, are they willing to do the things I'm telling them to do? Because if they're not going to do it. Patient satisfaction with functioning of implants. So are the patients happy with their implants? Are they willing to take care of them? Because I've met people who are not happy with their implants and they don't take care of them. Patient perceived changes since the last visit. This is something we want to be collecting from our patients. We want to ask them questions like, have you noticed any mobility? Have you noticed a bad taste coming from the implant? What's going on with that tooth? Because they're there with that implant every day. You see them once every 3 months or once every 6 months. So they have a better idea of whether that tooth is healthy than you do just because you're looking at it. So questions to ask. Are you able to clean around the implant neck, right? You want to definitely be showing them that C technique and make sure they understand that the implant underneath the gum line is a very different ball game than their teeth are, right? It's much more narrow. So we want to show them how to clean around it. Do you have enough cleaning aids, right? Do they need some interdental brushes or do they have a water pick? Like, are they good? Are you satisfied with your implant function? So is it working? Or do they, they're like, no, every time I chew on it, it hurts. So I have to chew on the other side of my mouth. Well, that's not good. Are you satisfied with your implant appearance? Does it look nice? If it's something that, they're constantly trying to hide or they never want to look at, they're probably not going to take very good care of it. And then, do you feel any parts of the implant are loose? They know better than we do. Do gums around the implant bleed? I feel like I should say, do your gums around the implant bleed? This is important, whenever they're brushing or flossing, do they notice bleeding? Do you have a bad taste coming from the implant? This is usually if they have separation, they'll get a bad taste coming from it. And then, do you notice any changes regarding the implant? Dental implant maintenance visit. So implants are difficult to recognize intraorally. Sometimes when you're looking around in their mouth, it can be really hard to figure out, is that an implant or is it just a crown, right? Because some dentists are sculptors in there. So they do a really good job on some of these things and you can't quite tell. And how do you tell? You get x-rays. Dental charts should clearly mark the location of implants. I have had times where, I was cleaning someone's teeth and I wasn't sure whether it was an implant or a crown, and I had to stop and go look at my dental charting to figure out, what is this? And then review radiographs ahead of visit. So, I think all of your clinical instructors Probably at some point when they come into your room, they say, let me see your x-rays, right? That's because you don't know what you're looking at until you see those x-rays. So here is the prosthetic crown supported by an implant. As you can tell, it kind of just looks like a crown, right? It's hard to tell. Guidelines for professional recall and maintenance. So the intervals determined are going to be on an individual basis. What does that patient need and what are they willing to come in for? 3-month interval is usually appropriate for that first year because you want to be monitoring that person. It's almost like, yeah, you're checking to make sure the implant doesn't fail, but you're also kind of checking on that person, make sure they can do what they need to do. Schedule appointments as frequently as necessary to keep peri-implant tissues healthy. So here, if they're doing okay, then they don't need to come in as often. But if you're seeing a little bit of those signs of peri-implant mucositis every time they come in, you want to get them on a more frequent interval. More frequent intervals if reduced bone support, inflammation, or host response due to systemic conditions. So, if in the kind of staging and grading of your normal patient, if you grade that person and you find them at a B or a C, you're probably going to want them to come in a little more often. Implant stability evaluation. So implants should not have mobility if they are osseointegrated and healthy. Here you want to assess the mobility of a natural tooth, right? It's the same. So you, just like with the natural teeth, you have to use the non-instrument side, so the handle side of two instruments. Here they recommend that you use plastic handles because you don't want to, be using metal to kind of cause that implant to rock back and forth. And then a radiographic evaluation is indicated for a mobile implant. So if, the patient's like, they come in and their chief concern is, my implant is mobile, well, you're gonna check, yeah, oh yeah, your implant is mobile, and then take an x-ray. Implant mobility indicates a lack of osseointegration or a loose abutment, or loose internal screws attaching the abutment post to the implant fixture, or a fracture of the implant, or that could, I'm going to add this in, fracture of the bone around the implant, or a prosthetic failure between components. The guidelines for professional maintenance. So here, residue left on the implant body is a significant cause of implant failure. And what do they mean by residue? Well, not just calculus, not just plaque biofilm, but also cement. So it's important that we are removing any and all residue from the implant body. Implant material is rough to allow for better osseointegration. Subgingival cement or calculus deposits require slender instruments made of compatible metal. So this is different. Most hygienists have always thought of implants as only being allowed to use plastic scalers, right? And this is no longer the standard or the recommended type of care for implants. Implants need to have a titanium instrument used if the abutment, if the implant is made of titanium, you want to use a titanium instrument. The reason for titanium is that it is a softer metal. So what you don't want to do is take your metal instruments, your stainless steel, I think is what they are. You don't want to go in there with stainless steel and scratch the surface of the titanium, because if you scratch it, it's going to allow more bacteria to adhere to that area. Okay, if you scratch someone's implant, you could very well be the reason why that person loses their implant. Okay, don't do that. Use a titanium instrument around an implant in order to remove residues. Special considerations for polishing. So implants, abutments, and components do not require routine polishing. So polishing on every tooth every time is not the required or not recommended treatment for people. You don't need to polish every time. Sometimes, however, patients are like, no, they're not clean unless you polish them, right? So if this is the case, you can use a rubber cup with a non-abrasive polishing paste if you absolutely have to polish that person's teeth or their implant. And then the best thing you can do is use air polishing with glycine powder. That is going to be the safest, most effective, and biocompatible with the implant as long as you're gentle with the soft tissues. The important thing here with the supragingival air polishing is that you don't direct that air polishing or the air coming out with the glycine powder. You're not going to direct that down into the sulcus, right? Because you don't want to do that. So you're going just across the gingival margin and kind of through the interproximal space. You are not directing it apically. Patient self-care of dental implants. Meticulous self-care is of utmost importance in preventing peri-implant disease. Well, let's say that again. Meticulous self-care is of utmost importance for preventing peri-implant disease. If that person is not willing to take care of the implant, or they're not capable of taking care of the implant, then there's not a whole lot you can do as a hygienist. And it's hard for a lot of hygienists because we feel very responsible for for our patients' teeth and for their implants. And ultimately, it's not our responsibility, it's theirs. Individualized self-care developed for each patient. So when the patient comes in and things aren't working out for them, you can see they're clearly struggling with their oral hygiene. That's a good time for you to figure out what's important to that patient and how do you get that patient to do what you need them to do. So, going through not only what they believe and how they understand the care of their implant, but also what are they willing? What are they willing to do for it? Porcelain, acrylic, or composite tooth fits over abutment. So depending on what the crown is made of, that's going to determine what the patient should be doing and your kind of care of it as well. Crown covering an implant may be larger in circumference than the abutment post. So here in this one, it's really important that you show them how to C-shape technique, how to contour the floss around the tooth. And then when they go in, they're going all the way into the abutment post, which is going to be a very narrow space. So the bulky crown surface is going to contact the tooth, and then it's going to dip in where it meets the post. And you need to teach that patient how to clean that spot. It's going to look like this. So the bulky crown supported by the dental implant. Here you can see that floss is it's almost to the center, right? So the floss in the photo is against the implant abutment. Note the very tiny width of the abutment compared with the width of the crown. I know we're past an hour, but stick with me. We don't have too much further to go. Techniques and devices. So a standard toothbrush, a soft one, not a hard one, not a medium one, a soft one. I typically will always recommend extra soft. But anyway, standard manual toothbrushes are appropriate whenever a patient is doing okay, when they have the manual dexterity to brush their teeth. If they have any loss of manual dexterity or they seem to have a difficulty kind of thing, powered toothbrushes are also a good option. They're not, the only way to clean it. Interdental brushes, if you're going to give your patient interdental brushes, right, a proxy brush, it's important that the wire that's in the proxy brush have a coating, right? You don't want to give them one that has a plain wire because patients get they know how to get in there with this thing. And if they're, in the process of getting it, they use that wire to scratch their implant, the titanium post that is holding it up, then they will cause a site of attachment. So we don't want to do that. Whenever we're giving our patients with implants proxy brushes, we want to make sure they know, use the ones that don't have the wire exposed. They want a protective coating. Tufted dental floss can be a very effective combination for patients who have those large embrasure spaces. A lot of people with implants have a little bit bigger of embrasures because they've dealt with some perio in the past, usually. Oral irrigators can be used or may be used. Oral irrigators are great. There's been a lot of evidence that shows that in some cases oral irrigators work better than flossing. It's kind of sad, but it's true. So it's on page 181 in your book. It's under techniques and devices. E, it says oral irrigators, and number 1, it says the study results demonstrate that the water flossing group had statistically significant greater reduction in bleeding than the dental floss group. It's there in print, right? So while yes, flossing properly, like you and I as hygienists, we know how to floss our teeth. So Of course, we do a really good job, and that is the best way to do it, mechanical removal of the biofilm. However, if they can't reach the area with regular floss, or they're not willing to reach the area with regular floss, then by all means, let them use an oral irrigator. And then daily antimicrobial mouth rinse can be beneficial. Here it's important to recognize that they wouldn't be using chlorhexidine every day forever, because chlorhexidine isn't a long-term use kind of rinse. But you know, the Listerine or Act is a really great one. Colgate makes some good mouthwashes that will help to reduce the bacterial load in someone's mouth. Can be a pretty good thing to do. If they don't like the taste of it, or they don't want to do it, you could always give it to them on like a little cotton tip applicator. Not, well, I mean, in their eyes it's a Q-tip, right? So if you put a little bit of a rinse on a Q-tip, and then you kind of just rub the tissue very, very gently around the implant, that would be beneficial as well. Care of removable prosthesis, so similar to a traditional full denture. I've cleaned a lot of these where they take the whole denture out and they've got just the implants, and the implants, it kind of like clicks into the implants. They're held onto those abutment posts by O-rings, magnets, or clips. You'll see a picture of this on page 182 in your book. It's also referred to as an overdenture. That's a really weird textbook way to say it. The way that most people talk about this, or the layman's terms, they'll call them like all on fours. And you can see in the picture there's 4 implants. So all of the teeth are all on 4 implants is how that kind of works out. And then the patient can remove it to clean around the abutments. So they have a full denture, and they need to basically keep it from moving around. One of the main things about dentures that are so terrible is that, you know, the patient can't hold it to the tooth. It doesn't stay against their alveolar ridge. So when they try to eat or talk, the denture kind of clicks around, or it moves around in there. So the implants are a great way to hold that denture in place. This is what that might look like. So the implant-supported prosthesis, they have a full denture, and inside the implant, which you'll see in your book on page 182, they have these little like rubber O-rings inside the denture part where the abutment sits in, and it kind of creates like a little click as it goes in. And that's that. The patient has to take it out, clean it, brush out the denture with a denture safe brush and a denture safe paste. And they also have to brush these implants just as if they were teeth. So the tools for cleaning around the abutments is going to be a soft bristle brush. Absolutely, absolutely has to be soft. Single tufted manual toothbrush. So here, you know, you want to give them kind of smaller ones. You don't want to give them giant ones. I wouldn't recommend end tufted. That's not what we're talking about here. Interdental brushes with nylon wire. So this is in your book on page 182. You can see that they have the ones with like the bar that goes across. So there's the implants and then the bar, and the denture will click into the bar. I haven't seen that one in private practice. That one would be an interesting case. But with that one, you might be using some of that floss around, and then using tufted dental floss. I mean, patients are funny because you'll call it like yarn, but they think that's great. And then here with the dental floss with the bar, you could even just use a 2x2 gauze to kind of clean it around underneath that thing. Oh, there it is. That's what that looks like. So the bar, you kind of use a 2x2 gauze and just go in there and kind of rub around it. You can see that, I mean, there's a lot of saliva there, but you can see that the tissue around these implants is actually pretty healthy. You're not talking about like this rolled margin right here, because it's just the contour of the tissue, but you can see a very uniform color of the tissue around these areas. This patient has a pretty good home care. And that's the end of this chapter. So get ready for chapter 10.